Ken is associate professor and the chief of allergy and immunology at LSU. And Virgil is, tell me your professorship, associate, full professor in the Netherlands at the Erasmus. You're all professors. Anyway, so I'm going to sit down and, you guys familiar with this? Or?
Not mad.
Okay.
So welcome everybody. First of all, thank you for, Lindsay, thank you for inviting me again for this third time now that I'm in San Diego for this meeting. And I'm a bit nervous because Ken decided this morning we always do this presentation together. He starts and I come second. And now he said, well, you have to start now. So I'm a bit shaky, but I will try to do my best. And what I try to do this afternoon is try to give some more information or some background about, let's say, the immune system, and especially with relation to 11q disorder, what goes wrong in the immune system. And as already introduced by Paul, I'm an internist clinical immunologist and focusing on care for adult patients actually with inborn errors in immune cell function, so treating patients with inborn errors leading to immunodeficiency. I'm working in Rotterdam, the Netherlands, and just to be clear, the Netherlands is not the capital of Copenhagen. Actually, the Netherlands is a small country located in Europe, as seen over there. So, why do we need our immune system? Well, very simple. The immune system protects us actually from everything which is threatening our, let's say, health. And the immune system takes care of viral infections, bacterial infections, fungal infections, parasites, so all kinds of microorganisms that don't need to be in your body. They need to be the immune system tries to get rid of those invading microorganisms and has to prevent you from getting sick by disease-causing microorganisms. And this immune system is a very complex system, as just shown on this picture. Don't try to recall it, but you just have to make sure that you recall that the immune system consists of various white blood cells, lymphocytes, T lymphocytes, B lymphocytes, neutrophils, macrophages. They will be discussed in more detail later by me and Ken. So it consists of white blood cells, it consists of several proteins, complement proteins, proteins involved in defense mechanisms of the immune system, and also antibodies. And antibody deficiency is one of the major immunodeficiencies we see in general, but also in patients with the 11q disorder, and I will come back to that later. So just to recall, immune system consisting of various white blood cells, proteins, all interacting to prevent you from getting sick by infectious causes. So what do we need? We need proteins, we need cells, we need antibodies, so actually we need good players in a good lineup. Because it's a complex interacting system, you need all players, and you need them to talk to each other and to defend yourself against infections. So as an example, you need these good players, the Belgian soccer team, unfortunately the neighbors from the south for Holland. So you need good players and good lineup, because what happens if it goes wrong? You get this team. And you can imagine that with this team, your immune system sucks, right? So I would always try to tell my students is that the immune system functions as the perfect marriage. So for those of you who still believe in the perfect marriage, this is what it should be like. If you look at the immune system and look at the marriage, the immune system, consisting of several cells, proteins, antibodies, it needs to complement and support each other. Because without cells, without proteins, without antibodies, something goes wrong. So it is a system that needs to complement and support. Also, there is a need in overlap of function. If you lose certain white blood cells, it could be that other white blood cells take over the function. Right? So it is an overlapping function. They have to act together. There is an interaction between cells, proteins, antibodies. And very importantly, and I will get back to that later, you have to recognize self from non-self. So you have to recognize invaders, microorganisms. You have to distinguish between self and non-self. because you do not have to make a reaction against parts of your own body. Because if that happens, we call it autoimmunity, and you have autoimmune disease. So overactive immune cells reacting to parts of their own bodies, it leads to autoimmunity. Like in the perfect marriage, you have to eliminate intruders, microorganisms. You have to be able to learn from each other, but also from what happened before. So if you get an infection, let's say with bacteria 1, you get memory. The immune system builds up memory. So when you encounter the microorganism for the second time, you will get less sick or not sick at all. So memory is very important in immune cell function. And you have to be tolerant for things that are not dangerous. So you don't have to react very actively against microorganisms that are not disease-causing. So unfortunately, the perfect marriage also does not exist, so things go wrong, leading to immunodeficiency. I want to give you a short introduction about the cells, proteins that are involved in normal immune cell function, and I always try to include a video, and 90% of the time it goes wrong, but this video is showing you neutrophils. Those are the cells that are the first part of your immune system. This is a neutrophil, and this is a bacteria. And what happens when bacteria enters the bloodstream or enters the body, the neutrophils are the first cells that try to catch the bacteria, as you see in this movie. So the bacteria is moving around, neutrophils is chasing the bacteria, and you will see that in the end, the neutrophil will catch the bacteria, indulge it, and will eventually kill the bacteria. Seen over here, the bacteria is indulged in the cell. So this is an example of what we call innate, inborn immunity. So when a bacteria enters the body, let's say, for instance, via the skin, via the blood barrier, these neutrophils, those are inborn. You have them at birth. They will just recognize bacteria as being not part of your body, and they will try to catch it and to kill it. So it's a very easy and simple way of defense. This is the first part of defense of your immune system. Then the second part is more complicated, consisting of other white blood cells, T lymphocytes and B lymphocytes. And T and B lymphocytes are important for clearance of both bacterial and viral infections. T lymphocytes are most important for clearance of viral infections, for instance, warts, and fungal infections are also cleared by T cells. The other function of T cells is they help B cells acting against bacterial infections. So in general, we say T cells are responsible for defense against fungal infections, viral infections, and B cells are more important against bacterial infections. It's not that black and white because they have, as already discussed, they have to cooperate, they have to complement each other. But this is we try to distinguish the specific duties of these immune cells. So what are B cells like? Because B cell dysfunction is one of the major dysfunctions we have been seeing in patients with 11q disorders. So B lymphocytes, these are the cells that produce antibodies. It looks like this, and more easily it looks like this. So the antibodies look like Ys, and with this, let's say this cup, the antibodies can catch bacteria. Okay, they can recognize parts of bacteria. What happens then, also depicted in this movie, so blood cells are running through the bloodstream. Red blood cells, white blood cells, all kinds of blood cells. And when bacteria, like depicted over here, enters the bloodstream, this bacteria has specific parts on the outside of the bacteria. And these things are recognized by lymphocytes. So indeed, the lymphocytes, by the antibodies, these Ys, as you can remember, they catch up, as shown over here, to bacteria. The bacteria are then indulged recognized and indulged by these eating cells. So these antibodies are of major importance. When bacteria are running through the bloodstream, the antibodies recognize bacteria, and these recognized and attached bacteria are indulged by, let's say, the neutrophils as seen in the previous movie. So it's a complex system, T lymphocytes, B lymphocytes, and the antibodies. And these are the major organs that are involved in immune cell function. It's the spleen, it's the white blood cells, lymph nodes, the spleen, and also the bloodstream in which all the white blood cells are running around. Well, there was another picture in, but I will share that later. So what we see from the bone marrow, which is the source of all white blood, red and white blood cells, B cells, T cells, neutrophils, all develop from out the bone marrow. They go towards the spleen, they go towards other organs, and they develop into active immune cells, ready for defense against bacterial infections. One of the most important problems we encounter in immunodeficiencies is a problem in antibody formation. So B cells, the B lymphocytes that produce those proteins, those Ys, those antibodies, those are the main problems that we find in immunodeficiency disease. So in general, when we look at primary immunodeficiencies, 60% of the problems is caused by antibody dysfunction. What is the result of these kind of problems? Recurrent infections. If people lack IgG, lack immunoglobulins, lack the antibodies, or have a reduced function of these antibodies, they have an increased risk of infections, like shown over here. Infection of the sinopulmonary tract, which means otitis, sinusitis, and pneumonia. So mainly sinopulmonary tract infections and gastrointestinal tract infections. We see Giardia, Campylobacter of the gastrointestinal tract, so diarrhea is one of the major symptoms. So antibody defects resulting from diminished production of antibodies or reduced function of these antibodies caused by B cells results in sinusitis, otitis, and pneumonia. Also, other severe infections can occur, abscesses, skin infections, osteomyelitis, but preliminary upper and lower respiratory tract infections. So these are mainly the result of a decreased production of the antibodies, these Y-like proteins, or a decreased function. And I want to repeat this over and over again because we always think we measure blood, we measure normal levels of immunoglobulins, so the antibodies, all the Ys are there, but still we have recurrent infections. Yes, because it's not only the level of antibodies, but also the function of the antibodies. We sometimes tend to forget that we have to look in more detail in functional testing. Do these antibodies that you might have, do they actually work as well? The other way around, defects in immune cell function, as already depicted in one of the previous slides, may result in autoimmune disease. So you have a reduction in immune cell function, resulting in an increased risk of infections, but defects in immune cell function may also result in autoimmunity. Like, for instance, rheumatoid arthritis is an important autoimmune disease, but also other autoimmune diseases may occur in people with immunodeficiencies. So this is one of the pictures that is very important to see where comes the immune system from the bone marrow, evaluating either in the thymus to T cells or in the spleen to B cells. If something goes wrong in this process, you might end up with reduced number of T cells, reduced number of B cells, reduced production of antibodies, which results in increased risk of infections. And do we see these infections and defects in the Jacobson syndrome or 11q? Yes, we do. A picture over here from a patient from our outpatient clinic in Rotterdam with severe warts all over both hands, all over both feet as well. So viral infections, HPV virus is causing warts, seen in a guy who was at that age 23, 24 years of age. This is not normal. Young children may have warts, but extensive warts at this age is it's very suspect to be related to an immunodeficiency. The picture over here showing a pneumonia of the right upper lobe of the lungs. Severe pneumonia can be seen in 11q disorders due to potential immune cell defects. And is this new? Well, no, not at all. As already mentioned by Paul, published around 15 years ago, the series of over 100 patients with Jacobsen syndrome. It was already described over there that in a major number of patients, it was already demonstrated 14 years ago that indeed recurrent infections are a major problem in 11q disorder. And over time, you see scattering around several publications on immunodeficiency in 11q disorder. So cases all around the world describing indeed 11q disorder in relation with immunodeficiency. So indeed it has been recognized several times. And this is a summary, and I don't know whether this is readable, but what it shows that indeed in a series of 6 patients collected from literature, decreased production of antibodies, decreased function of antibodies has been described in a series of a number of patients worldwide, showing the increased risk of, let's say, bacterial infections, a B-cell problem. So as we were interested in seeing what is going on in the immune system in Jacobsen itself, we started a small study in the Netherlands. This was not a Dutch patient, but at that time living in Belgium and already shown by Paul. It's Robin Olney. And we included 6 patients with Jacobsen syndrome with a deletion in 11q, so they all have a deletion of 11q. And what was really striking indeed, as already mentioned by Paul, that 5 out of 6 patients showed low numbers or low levels of immunoglobulins, so low levels of antibodies, disturbed function of the antibodies. So not only the levels were low, but they were also reduced in functional assays. And what was very striking is that there was a decrease in the total number of memory B cells. And what are memory B cells? That's what I tried to show you in one of the first slides. It's very important that your immune cells, your immune system builds up memory so that you don't get sick over and over again from the same bacterial antigens. Normally, you get an infection with, let's say, bacteria A, you get sick, but your immune system remembers this bacteria, builds up memory, so when you encounter the same bacteria again, you have memory which leads to a direct reaction of the immune system against that bacteria, which prevents you becoming severely sick. So memory, building up memory, is very important immune cell function, preventing you from getting sick over and over again from the same bacterial agent. And this is why you need these memory B cells, because the name says it all, they build up this memory against bacterial infections. And what we found in the patients with the 11q disorder, there was indeed an a decreased number of these memory B cells. So a decreased potency in building up memory against bacterial infections, which may result in getting the same infections over and over again and getting sick of these infections over and over again. And this is depicted over here, and you don't have to recall this, but it's really important to remind you that there is a decreased number of memory B cells, decreased memory in these patients. And what we found, and this is more clearly, that indeed when you look at a healthy control population, so on the left side we included some healthy people from our labs. You see there were relatively normal levels of total B cells, and diminished in the 11q patients. And more importantly, these memory B cells, those were very, very low in 11q patients. So from the B cells, memory B cells are a part of the total number of B cells. You see there is a significant decrease in these total levels of memory B cells. So what does it look like? And we published the paper, as mentioned by Paul 3 years ago now. We have common variable immunodeficiency, which is for our clinical immunologist colleagues, one of the major primary inborn immunodeficiencies that we know of. And we speculated at that moment that indeed Jacobsen syndrome looks clinically, when you look at the immunodeficiency, comparable to common variable immunodeficiency, which is characterized by recurrent sinopulmonary tract infections, recurrent otitis, sinusitis, pneumonia, but also recurrent viral infections, because also the T-cell function might be diminished. Because we're talking about bacterial infections of the upper and lower respiratory tract, but what about other kinds of infections? And we were just discussing last night over a beer again. What did we hear today? Because we were in touch with several families yesterday afternoon, and we see a lot of people suffering from skin infections, fungal infections from the skin, warts, other skin infections. So we're talking about bacterial infections of the sinopulmonary tract, but we also see that fungal infections, warts, viral infections are a major problem for a number of patients with 11q. It's not only explained by defect in B cells, so there might be more going on, not only in the B cells, but also in the T cells that we have to pay attention to. So that's what we suggest, that apart from T cell, a B cell dysfunction, there's also a T cell dysfunction. It was already mentioned in the previous talk that indeed by newborn screening, it was picked up that the number of patients had low T cells from birth, and they were found to have 11q disorder. So we see in a number of patients that there is a reduced number of these T cells, which might be leading to increased risk of fungal infections and viral infections. So it's not only B cells, but also T cells. You see it's a complex disorder. The main question that still remains is, why is this immunodeficiency there? Because we see defects, we see disturbed immune cell function, but why is it in Jacobsen? Very easy. It should be something, it should have something to do with, let's say, genetics, because there's a genetic defect, and we think that should be the cause of immunodeficiency. There is a deletion in chromosome 11, and what we know is that, of course, there are a lot of genes in this chromosomal area that is deleted. And one of the genes that is mostly known of is the ETS1 gene, which is, of course, involved in cardiac development. But what we know from mice studies, of course, mice are not human, but what we know from studies in mice, that indeed when you have a problem in the ETS1 gene in mice, it results in a disturbed development of immune cells. So it might be suggested that also the defect or the lack of ETS1 gene is involved in this immune cell dysfunction, although this has not been proven in human yet. So what I already said, in mice that has been shown. Another gene that might be of interest is the FLY1 gene, which is also on that area of the chromosomal, chromosome 11. It's also known that this is involved in normal immune cell function. It is a very complicated picture, but it just wants to show you that indeed FLY1 defects result in disturbed immune cell function. This is all suggestive, has not been proven, and actually we still don't know. Is it indeed a genetic defect in one of the genes on chromosome 11, or is it more complicated, and is it a problem on other genes that are causing the immune cell dysfunction? But we still do not know. It might be genes on chromosome 11, it might be that there is a problem on other genes in other chromosomes. So it's still something to look into in more detail. So what are our main goals for the upcoming years? I think we have a clear idea now that indeed in the majority of people with Jacobson syndrome, there's a disturbed B cell function, disturbed production of antibodies, disturbed function of antibodies, and increased risk of bacterial infections, otitis, sinusitis, and pneumonia. But the interesting thing that we are still not well informed about is what about the T cell function. We know there is a decreased number of T cells in a number of patients with Jacobson, resulting in viral infections, resulting in fungal infections, but this is still something to explore in more detail. And of course, it will be of interest to see what kind of genetic defects are causing immune cell dysfunction. So to conclude the first part of this presentation, and Ken will take over, is that I think a large number of people with 11q suffer from recurrent infections, mostly due to disturbed production of antibodies or a disturbed function of antibodies, which are leading to the increased risk of infections. And I think, and also Ken will support that all patients with 11q disorder require immunological evaluation. I would like to end my part of the talk, and I will give the microphone to Ken. Thank you.
Thanks, Virgil.
Wait, is that yours? Yeah. Go ahead and,
Yep.
yep. I'm going to try again.
Yeah, it's fine. Perfect.
Should be in business.
Great, thanks everybody. So I think for Virgil and I, this is one of our favorite meetings to be invited to speak at and participate, because we get to actually interact directly with the folks that actually benefit the most from what we have to teach. You know, oftentimes there's physicians or students in the way, and we never really know how well what we teach them gets translated to you, but we've got a direct line, and it really gives us an opportunity to make a big impact. So I want to thank everybody and the organizers for inviting us back to speak. Before I talk, how many people here have children that were born after about 2010 or 2011? Good, so a fair number. And I'm going to ask everyone a little bit later, if you think about it, if you know whether they were identified at the time of newborn screening or not. Because some people probably say they know, because I'm talking with some other investigators in the US about maybe getting some information from all of you about those, about your children, so we can maybe do a little bit more in-depth research on that. So let's see. Perfect. We're ready to go. So I'm going to repeat some of the things that Virgil talked about, and then add a few things about management and clinical decision-making for patients with Jacobson syndrome. As Paul mentioned, we came up with a protocol about a year or two ago, which is now on the website, and I'm also going to review that. So Virgil did a very basic immunology lecture. You're all going to be tortured now for another half an hour with more immunology, which is probably physicians' least favorite topics in medical school. So I have three objectives today. One, I want you guys to just be familiar with the immune system in children and adults. I want everyone to understand the features of immune deficiencies that we have seen in patients with 11q disorders, and also at least be familiar with some of the recommendations that we've come up with and that may help keep your children healthy. This is nothing that you need to memorize. We have all this information now on the website, and feel free to email or ask either of us, either while we're here at the conference or even after, if you have questions. And I know some of you have actually already emailed me over the last 2 years, and sometimes I reply quickly, sometimes not so quickly. I usually do reply, but maybe not right away. Okay. So let's think about what is immunity. This is a little bit of what Virgil already talked about. So the immune system is designed to keep us healthy most of the time. You know, we all get sick every once in a while. That doesn't necessarily mean we have an immune deficiency. It just means that the infection, for whatever reason, sort of was a little too much for our immune system to handle right away. But eventually, we fight it off, and we recover, and we're fine. The way that it functions, as Virgil said, is team effort, right? So it's multiple different types of cells, multiple proteins, multiple actual body organs. So whole organs can be considered to be part of our immune system. They work together, sometimes separately. They work apart from each other, but they really just protect us from infection. Of course, Virgil outdid me with a movie, right? I have a picture, but it's the same, right? I shouldn't have let him go first. So my little picture here is a food particle actually covered with bacteria. And it's just in this lecture, every time I give it, to make everyone recognize that we're exposed to bacteria and viruses every single day, right? Everyone's eating something, there's bacteria on all of our food, it's on our hands, right? It's everywhere. Yeah, everyone's like, yuck. But it's so true. We all have Staph aureus bacteria on our skin. Sometimes it causes a little infection, you get a little, abscess or something, but we're able to clear it. So the way it does that is the immune system responds to a danger signal. I do this a little bit more simply. I use little cartoons to teach people about the immune system, especially med students and families. And I use little characters that I pulled off the internet. So the first character in the immune system is actually the bad guy. It's the enemy. It comes in various different forms and really is the bad guy that attacks your body. It's usually a bacteria or a virus. Bacteria like Streptococcus pneumoniae, which is the bacteria that Virgil mentioned earlier. Staph aureus is another, or Staphylococcus is another bacteria that can cause problems for people. Viruses, simple cold viruses, can be considered to be the danger signal or the enemy. And also, and I don't list it here, fungus. So as one of my colleagues called it, mold. So mold, it's a different type of mold than what grows on your shower wall or in water-damaged sheetrock, but mold or fungus can also be a big problem and a danger signal that our immune system has to recognize and fight off. The immune system is also composed of physical barriers. Those physical barriers include the skin, right? So your skin is considered to be part of your immune system, and it physically prevents bacteria or viruses from entering it. The picture on the right is perfect, beautiful skin on the top that is intact and able to defend from invasion. But any sort of open cut or wound, like in the middle picture, would allow for bacteria to enter the body, okay? Mucous membranes, so our mouth, our nose, our sinus cavity, our entire GI tract, actually, is covered in what we consider to be a mucous membrane, and that has properties that also protect us from infection. The body fluids, saliva, mucus production within the nasal cavity, your tears, is also in some ways a physical barrier to infection. So it can wash away larger particles, so bacteria and fungi or mold, and prevent that from causing infection. Each one of these actual physical barriers then has a component to it that we consider to be a, sort of a biological immune system. So the cells that I'm going to discuss in the next few slides actually reside in these physical barriers in various ways, so that if a bacteria or a virus or fungi gets through the physical barrier, your immune system will be able to protect you and fight it so that it hopefully doesn't cause an infection. As Virgil mentioned, the neutrophil is really the first line of defense. It's part of our immune system that doesn't change over time, and we're born with it functioning at its peak capacity. It really doesn't have any sort of development behind it. It won't really change from birth till death. And it's probably not something that is impacted by 11q disorder. All of the children and adults who are affected by 11q probably have completely normal neutrophil function. You're able to kill bacteria by producing toxic substances. It's really complicated. And those substances actually then produce abscesses. So most of your children probably don't have problems fighting off Staph aureus, for example, and don't have infections of the skin above and beyond what most children have, with the exception of fungi and warts. The next part of the immune system Virgil mentioned is the T cell. T cells are really good communicators, but also they're very good killers. They have different subtypes to them. One is a really good communicator, and as Virgil mentioned, it talks to B cells and tells them what to do. But there's another type of T cell which is involved in direct killing of the danger signal or of the bad guys. And we think that that's probably one of the immune cells that's, at least in some patients, defective in 11q disorders, which explains the severe infections in some patients and also some of the viral infections of the skin like warts and fungi. Because the T cells are probably affected by 11q, the B cells are probably also impacted. The T cells can't talk to the B cells in the right way, and probably that's the problem that causes B cells to be low in the patients like Virgil reported in his paper a few years ago, and also in the patients that I've seen. So B cells in this cartoon can be considered to be the war factory. It's the place where you make all of the bombs, right? Consider the bombs to be antibodies. They make the antibodies that defend us against the danger signal, and then they do that because they've received information from the T cells telling them what to do. The T cells and the B cells talk to each other, then the B cells make antibodies, which are these little proteins Virgil talked about. Consider these to be the bacteria and virus soldiers. They are always circulating in your bloodstream, and they're waiting for those danger signals to enter the bloodstream so they can go stick to them and help your body clear those danger or those bad guys. They're the little proteins that were in Virgil's talk were little Ys, right? And that top part of the Y is what sticks to the danger signal. They can prevent viral infections. They can neutralize some of the toxins that the viruses and bacteria produce, and they do this by sticking to them with that top part of the Y. So when all those parts of the immune system work great, you have a normal immune system. But what happens when they don't? We consider that to be an immune deficiency. So immune deficiency is a term that describes what happens when the immune system is unable to protect us from those bacteria, viruses, and other danger signals. Primary immunodeficiency is when you have an immune deficiency that, as Virgil mentioned, is hardwired into your DNA. You're born with this inability to fight off infections. There are other reasons to become immune deficient. If you think about patients who are receiving chemotherapy for cancer, right? They're taking medications that can impact their immune system and make them more susceptible to infection. Patients who are on long-term steroids, right, for various diseases. Maybe some of you in the audience have family members who say, oh, my immune system is weak because I'm on a certain medication. That's a type of immune deficiency. HIV infection is probably the most common immune deficiency worldwide. That's where an outside virus actually impacts your immune system and makes you unable to fight off other infections. But what we're talking about for our talks are forms of primary immunodeficiency, where some part of the immune system is inherently broken or doesn't develop in the normal way. There are different forms of primary immune deficiency. They can be severe, life-threatening, fatal within the first year or two of life. They can also be very mild. They can not show their face until patients are young adults or even older, and may only predispose patients to very mild nuisance infections, like I call them. I think in Jacobson syndrome or 11q disorders, we see the whole spectrum of immune deficiencies. We might see patients who have very severe immune deficiency identified at birth, but I think we also have patients in the 11q family who might have more mild forms, like Virgil mentioned, which are very difficult to identify because all of the testing looks pretty normal. The type of deficiency also predicts the type of infection that you're susceptible to, and Virgil mentioned this. So for example, in this graph right here, the pie chart, the patients who are in what I would consider teal green here, the largest part of the pie, so the 50% who have antibody deficiencies, are mostly susceptible to infections like ear infections caused by viruses and bacteria, sinus infections, and maybe some pneumonia if they have severe antibody deficiencies. The patients who are considered to have T-cell deficiencies, so up in the top in sort of light purple or pink, are susceptible to viruses, to warts, to fungal infections, and to very severe infections caused by strange, unusual bacteria that kill you. The people in purple, in combined immune deficiencies, are susceptible sort of to all of those things in various forms. I think patients with Jacobson syndrome mostly fit in the green to purple, and a very small number fit in the top pink part. But those top pink patients are the ones that we really don't want to miss because they are the most susceptible patients. So how do we test for immune deficiency in Jacobson syndrome? So it's not something that we can just look at a patient and know that they have a disease. You have to do some fairly complicated laboratory evaluations in order to identify deficiencies. And even with the complex testing that we do, sometimes we just don't have the method to do the test yet. Over years, we've perfected all the different laboratory testing, but we still aren't there for some of the problems that we think affect patients with Jacobson syndrome. Virgil mentioned that we all need to do some functional testing, and that's sort of where we lack the expertise, I think, sometimes. We just aren't aware of how to do those tests yet. So it requires blood testing to measure antibody levels, so all patients will need that. It also requires blood testing to measure T-cell and B-cell numbers to make sure that they're present in the blood. And sometimes we need to use a vaccination to challenge the immune system to make sure that all of the pieces and parts are working together to actually have a good team and make those antibodies in the end. When we do the testing, how do we know when something is normal? So I would say that a normal immune system is one where the patient has normal immunoglobulin levels, so normal levels of IgG, IgA, and IgM, and these are lab tests that your physician would do. Keep in mind that the normal levels actually change with age. So lower levels of IgG in the first few years of life are normal, but those lower levels, if we measured them in somebody who is 15 or 18 years of age, would be considered very low and abnormal. So it's something that has a developmental progression. A normal immune system is one where immunizations trigger the development of specific antibodies that would protect you from infections. So we need to document normal responses to diphtheria and tetanus vaccination, as well as vaccination for a bacteria called Streptococcus pneumoniae. A normal immune system is also one where they measure normal T-cell numbers and B-cell numbers. And that starts with a simple white blood count, which is performed on probably all kids with Jacobson syndrome because it's part of a complete blood count, where we measure platelet levels. I would say that normal T and B cells could be measured by doing T and B cell lymphocyte testing. That's something that all immunologists would know how to do. And in the US and some countries in the EU, normal T cell and B cells can be documented or measured with normal newborn screening, which is done on most children in the US at this point. So if we have a normal immune system from a blood standpoint, what symptoms in 11q disorders may suggest an immune deficiency? So as Virgil mentioned, chronic respiratory infections, so ear infections, sinus infections, and lung infections may signal that something's amiss. Chronic diarrhea can occur in patients who have various antibody deficiencies. Oral and diaper thrush, as well as other fungal infections. So severe foot fungal infections or athlete's foot, severe diaper dermatitis or tinea capitis or ringworm, and that's a picture on the right-hand side of classic tinea corporis or ringworm, might signify a need to evaluate someone's immune system. And then also recurrent or severe warts, like we saw in the picture that Virgil presented of that man with all those warts on his hand. So one of our patient advocacy groups for the immunology world is the Jeffrey Modell Foundation. And they've put out some literature really trying to spread the word about what would prompt the need for an immune evaluation in patients who might have immune deficiency. There's a list here. I can easily get this for everybody or even have maybe somebody put it up on the 11q website. So it's essentially warning signs like too many infections, infections that require IV antibiotics to clear, infections that require hospitalization, infections with unusual bacteria, viruses, or other organisms, a family history of an immune deficiency. And while it's not listed on this list, I think a diagnosis of a known syndrome that has immune deficiency as part of it would be the number one warning sign, or one of the top warning signs that your child could have some form of immune deficiency. Virgil went through this already, and I'm going to go through these slides really quickly, but what immune deficiency do we see in patients with Jacobson syndrome? So common variable immune deficiency, where we have low antibody levels and a poor response to vaccination. Some patients have some low T cells, and they have recurrent infections that are listed here. This has been reported over and over again, I think, in patients with Jacobson syndrome. Also, patients with JS can have just hypogammaglobulinemia, where one of the immune globulin levels, so whether it's IgG or IgA or IgM, can be low. They may actually have normal responses to vaccination, but they still have infections with recurrent bacteria that causes ear, sinus, and lung infections. T-cell lymphopenia is another form of immune deficiency where we have either low T-cell numbers, low T-cell function, or both. These patients, as you may have learned over the last 45 minutes or so, have recurrent infections with viral or bacterial pathogens. And Virgil alluded to the fact that maybe we can see patients that have normal T-cell numbers, but where those T-cells just don't function well. And that's kind of hard to identify, at least at this point in the lab. And then this is how I got involved in this sort of journey with 11q disorders, which is the identification of patients with severe T-cell lymphopenia identified around the time of birth. As I think Paul mentioned, since 2010, there's been this newborn screening push in the United States to identify patients with severe combined immune deficiency, which is a severe form of primary immunodeficiency that's fatal in the first year of life. And a newborn screen was developed to identify at-risk children within the first week after birth so that we could initiate a life-saving treatment. And when that was rolled out to some of the states in the the mid-2000s, so like 2009, 2010, 2011, some patients with Jacobson syndrome were identified as having an abnormal newborn screen. And my state was one of the first states to start screening. And we identified within the first, I think, month or two, a patient with severe T-cell lymphopenia. So we found that she had very, very low T-cell numbers, probably low function, although at the time, everything that we were able to use to evaluate her showed that she had normal T-cell function. It looked like she made immunoglobulins and had normal responses to vaccines. And for the first year or two, she actually had few infections. But eventually, she passed away, partially because she had some very severe underlying physical problems. Severe lung damage from birth, as well as cardiac problems, and she didn't make it past her 4th or 5th birthday. So this finding has prompted sort of other investigators in the US to start questioning whether they have seen patients identified on newborn screening. And every state now where they've been screening for these T-cell deficiencies have identified at least, I think, one patient with JS. So this slide I created this morning just to highlight the differences of the way immune deficiencies were identified before newborn screening started and what it looks like now. So on the left, you see before 2010. So a baby was born and was identified with Jacobson syndrome, probably because they had a congenital heart defect, maybe they had low platelets, maybe they had classic appearance of Jacobson syndrome and was seen by a geneticist within the first week or two of life. They had the diagnosis and they were probably followed by a good pediatrician and some other specialists. Maybe they started having recurrent infections or other infection problems that people probably chalked up to some of the facial or bony abnormalities that we see in JS, so maybe a predisposition to sinus infections because of poor drainage or abnormal eustachian tube function. Maybe a few patients were referred to an immunologist, which explains why a few papers had been published in the early 2000s describing immune deficiency in Jacobson. And then maybe one or two of those patients actually had some laboratory testing which revealed maybe some immune deficiency. But it was only a couple patients, and they were so rare that they were reported in the medical literature. Now, with newborn screening, all babies in the US, I think by the end of 2018, will probably be screened for T-cell deficiencies. And within a week or two of birth, I think patients who have some of the more severe forms of immune deficiency will get an immediate referral to an immunologist for further testing and follow-up. That's great, but not every patient with JS will be identified on newborn screening, so we can't really use that as something to hang our hat on and not worry about. So I think it's important that we continue to develop this protocol that we put together a year or so ago to make sure that every child then is followed over the first few years of life to make sure that we don't miss immune deficiency that might be developing. So my next few slides are going to be the immunology protocol sort of summarized. It's online on the 11Q resource website for you to reference if you want. But this is the down and dirty sort of summary. So all newborns should have T cells measured soon after birth. That can be done either by newborn screening or by a pretty simple laboratory test that an allergist immunologist can order from any of the commercial labs in the United States or even worldwide. At around the age of 4 to 6 months, we think that every patient should have their antibody levels measured. So measuring IgG, IgA, and IgM. Around the age of 12 months, we can then measure how well patients or infants responded to the first series of vaccinations that they received to protect them. At about 2 years, it's important to have the immune system checked again and consider using Pneumovax, which is a very commonly used vaccination to protect against strep pneumo, which is a common bacteria, and measure how the immune system functions. This has an additional benefit because when you receive that vaccine, you then stimulate an immune response that protects you against infection with that particular bacteria. So even if children with JS don't have immune deficiencies, this sort of logical progression of testing and evaluation has a clinical benefit in that it can improve your child's ability to fight off a very common bacteria that causes ear, sinus, and lung infections. So it's not just diagnostic, it actually has some therapeutic benefits as well. We think that every child with JS should have at least one consultation with a clinical immunologist, if possible. We think that routine vaccinations can be given unless there's a known T-cell deficiency. So in the US, if you've had a child where Jacobson syndrome was suspected based on an abnormal newborn screen, I probably would not recommend all of the routine vaccinations until a complete evaluation by an immunologist has been done. In the first 1 or 2 years of life, we strongly consider and recommend using Synagis to reduce the risk of RSV infection. Part of that is because of the child that Paul alluded to earlier, who passed away after a life-threatening infection with RSV, and partially because we now know that patients can have severe T-cell lymphopenia, and that may predispose patients to severe RSV. And then all children probably should get Pneumovax 23 at about the age of 2. In regards to treatment of patients in this period of time where their immune system is being evaluated, we also recommend early treatment of infections with antibiotics. We recommend repeating the immunologic evaluation if, for example, something has changed, meaning the infections are becoming more recurrent, if they become severe, or if they're changing in any way. And we also recommend the use of prophylactic or preventative antibiotics in all patients with low T cells, because low T cells predispose you to some life-threatening infections, and in some patients with recurrent infections and who might have some immune abnormalities. Additionally, management of the antibody deficiency that we see in 11q disorders is the use of immunization. So as I mentioned, immunization with Pneumovax and maybe other shots. The use of antibiotics to prevent infections and also to treat, as I mentioned in the previous slide. And then in a significant, actually a significant proportion of patients, consider antibody replacement. So antibody replacement is where we use a commercially available plasma product called immunoglobulin, or IVIG, to supplement the antibodies that patients with Jacobson syndrome and other immune deficiencies may not be able to produce. And we can do that via the intravenous route, where an IV is placed in the vein once every 3 to 4 weeks, and immunoglobulin is infused. We can do that via the subcutaneous route, where a small needle is placed under the skin, and it's infused every 1 to 2 weeks. And we can also do it where a small needle is placed under the skin every 3 to 4 weeks, and a larger volume of immunoglobulin is infused to protect patients from infections. I think maybe in a future conference we could probably have a more detailed discussion about immunoglobulin, because I think as more patients are identified, there might be a larger group of people that would benefit from that highly specialized talk, just to discuss other ways or ways that you can manage in immunoglobulin infusions. How many people in the room are being treated with immunoglobulin now? Anybody? Nope. About two? Yeah, so I know there's a few people. One of the patients that, I think all the patients in your study, yeah, were on immunoglobulin. And this may be related to the age of patients. We think maybe the antibody deficiency is something that doesn't develop until later on. So maybe what we're learning is that repeated immunologic evaluation is something that we need to consider because it can change over time. So in summary, our immune system is complex. It works to protect us from danger. Some patients with 11q have immune deficiency and frequent infections. Probably all patients with Jacobson syndrome have some impact of the deletion on their immune system, but we don't know how to measure it at this point. And whether that impact on the immune system translates into a clinical picture of recurrent infections is something that we haven't really been able to show yet either. And we think that all patients with JS should be tested and treated to reduce and prevent infections. So I also put a few resources. These are 3 websites that I know and trust for people around the world. So in the US, there are 2 patient advocacy groups for immune deficiency. One is the Jeffrey Modell Foundation, based in New York City. Their website is www.info4pi.org. And the Immune Deficiency Foundation, which is based in Baltimore, that's www.primaryimmune.org. I'm involved with both of those organizations in various ways. And there are immunologists all around the country, in the US and the world, at various centers that you can find contact information for on these websites. In Europe and in other areas of the world, IPOPI is an international patient organization for primary immunodeficiency, and they have a very similar setup for patients that are affected by immune deficiencies. While Virgil and I are here, feel free to come up and ask us and tell us where you're from, because we might know a clinical immunologist that we trust in your area that we can make a referral to and maybe initiate a contact so that when you show up at a first appointment, you're not walking in and having to defend yourself of why you're there. I think I've helped a few people. I know Jessica, I've gotten in contact with her physician. She reached out to me by phone or email, and I think that's where we first made contact. I think. We may have met at a meeting, but definitely the first time, yeah. That's right. Exactly. So that's actually a really nice thing that I think Virgil and I are definitely willing to do, because it puts a face to the name, sort of, and you get, a little, hopefully, streamlined care that way. So I want to thank everybody for inviting us, and we'll take a few questions now. I don't know if we have time, but we're also going to be here. We're also going to be here this afternoon later if we want to do it. Lindsay, do you want to do a few questions now and then later? Sure, because we can get through that's perfect. Okay. And there's some people that may want to come in for the panel that aren't here now. So, sure. Question in the back. Sure. So Pneumovax 23 is approved for use in all individuals older than the age of 2. It's the pneumonia vaccine that you see on the sign outside of Walgreens and CVS. So it's effective in preventing infections in all age groups, but it's not a vaccine that you typically need more than once every so many years. So if a child's received it at the age of 2, they probably don't need it until many years later. But it can be used if the first evaluation is occurring at the age of 4, 14, 24, 34, it doesn't matter, as long as they're older than 2. It's not dangerous to use it in an age less than 2 from a safety standpoint. However, children less than the age of 2 who are otherwise healthy may not respond to it because their immune system is not yet developed in a way that allows them to get that particular vaccine. So we receive 4 shots in the first year of life called Prevnar. I don't know if anyone's heard of that vaccine. That's a vaccine that protects against the same bacteria, but it is designed in a way that infant immune systems will be able to make protective antibodies. So Pneumovax is just a form of that vaccine that is effective in older kids. And it's much cheaper to use than Prevnar, and it only requires 1 vaccination to become protected as opposed to the series of 4 shots that you would use in the first year of life. So that's the difference. But you could use Pneumovax in any age group. You had a question right here.
Hi, my daughter is one of the oldest with the Jacobson syndrome, but at an early age, she continued to be sick, in and out of hospital, all type of infections and things. As she got older and stuff, the fungal started and everything. Since the last conference, I think I talked with him. He told me to take her to a dermatologist, and she was diagnosed with skin cancer. And so she had the surgery, and that's all taken care of. So I don't know if it's, as they get older, is things changing with their immune system or what?
Yeah, so I'll let Virgil talk a little bit about, he's the adult immunologist. Go for it, Virgil. You might have to turn it on.
Yes, so it's a very interesting question. And actually, Jacobson specific, I have to say, we do not know. What we know, let's say so if we're talking about aging in life and aging of the immune system, we know that for all of us, over time, the function and effectivity of our immune system declines over time. So in general, yes, our immune system gets worse at increased age. How that is related to Jacobson, whether there is an increased rate of aging, we are not sure, but yes, that could be. And if we're talking about cancer related to immune cell defects, in general, we all make, let's say, cancer-like cells. But because of our immune system, the immune system not only defends us from bacterial infections, viral infections, but also our immune cells take care of, let's say, skin-like, cancer-like cells. When we get these cancer cells, our immune system gets rid of them. So yes, there is a relation between development of cancer and our immune system, because we say that indeed these cancer cells get the opportunity to grow when your immune system is relatively low. So these are all general, let's say, general aspects. So whether these are specific GS related, that's difficult to say because we have limited knowledge on the aging Jacobson patient and their immune cell function.
Yeah. It also might be complicated by the fact that certain skin infections can be associated with the development of malignancy or cancer. And for example, HPV or human papillomavirus is related to the formation of cancer in other organs, cervical cancer, oral cancers as well. And the combination of that particular skin infection plus maybe a poorly understood T-cell deficiency could increase the risk for those types of cancers in patients. Although we don't know for sure, but those two things together, for any immunologist or dermatologist, would make sense.
Yeah.
It would not surprise me if that is a risk factor for the development of skin cancer prematurely compared to other patients. So we had a question up in the front. Wait, because they want to use the mic so it's recorded.
My daughter's been on, and she's 8, and she's been on antibiotics essentially her entire life because she had kidney defects, and although they did the surgeries, her kidneys still don't function completely perfectly. So she's gotten kidney infections because of the bacteria growing in it, and she had the immunology testing, and they said that her antigens didn't proliferate properly. We just recently moved, and she's got a different doctor now, and he's suggested perhaps taking her off of her antibiotics. And is that something, he said that generally people, as they grow bigger, that turns into not being a problem anymore, and I just didn't know if maybe that's a good idea or not a good idea.
So I think from the urologics perspective, I would defer to them and to decide when to take the prophylactic antibiotics away, because they're being used to treat a very specific structural problem that predisposes her to urinary tract infections. Urinary tract infections are typically not part of any of the immune deficiencies that we care for. So for patients who have urinary tract infections on a recurrent basis, it is not related to immune deficiency.
Okay, because it's not from her bladder going up to her kidney, it starts in her kidney.
So that's probably a structural thing. But you just made me think of something really important, which is, Paul, what's the number of patients with JS who have kidney problems that might be on prophylactic antibiotics? About 10. Okay, so it's not that huge. So patients who are on prophylactic antibiotics for other things, those prophylactic antibiotics may be masking an underlying antibody deficiency, because you're essentially preventing the patient from getting sinopulmonary ear, because they often will use
She's definitely
amoxicillin.
healthier now than she was.
So
when
if
she
your
wasn't.
child is on prophylactic antibiotics for other reasons, that may actually be helping them and protecting them from the sinus infection or the ear infection that their antibody deficiency would make them have. So we've seen that before, where antibiotics have masked sort of the development of symptoms that would prompt, a physician to suspect an immune deficiency.
I was just wondering, sorry, wedding ring or not? Okay, turning it around, interesting. You mentioned that some of the numbers change with age, so it's hard to have normal levels on the, but then I was wondering if that was also true for the memory B cells and T cells, if there are like normal levels that we should be aware of that we're looking at, because we're in a second round of we started the whole immune evaluation after the first time Ken presented, and then we moved across the country and my son's infections got better and we dropped it, and now they got worse again, so now we're back in the process, and we've had B cells and T cells measured, and also he's getting the Pneumovax 23, and we're waiting for the results actually to find out about the titers for that. But God, this is awful. Oh, sorry. Okay, but I'm just wondering about, like, as we're getting the results back, if I could know what consists of a normal B cell or a T cell count. Because I remember when we first did the first round, I happen to have a close friend who is not an immunologist, but she's a neurologist, works with a lot of HIV patients. So I mentioned his T cell levels, and she said, I know they're low for an immunologist, but in my world, that's really high, so I wouldn't worry too much about it. We know his function could be fine with that level of T cells, but I'm just wondering, like, if I should, as these levels are coming back.
Yeah. So all of the testing that is done from an immunologic standpoint has age-related normals. So they all have age-related normals because these normal levels change throughout the lifespan until you get to be about 18, and then Virgil only needs to know one.
Yeah.
Because it doesn't change after 18 for the most part. While there may be some decrease or change in elderly individuals, between birth and about 18, it's constantly sort of, the bar is constantly changing. So, yeah, so the threshold exact changes. So, and it also depends upon what the, who the specialist is and what they consider to be normal and how they interpret that test. It's complicated. So I would have a clinical immunologist who's familiar in the treatment of primary immunodeficiency be the person to interpret the blood testing, or find someone who is willing to reach out to someone familiar with Jacobson just to give their 2 cents and help out.
Have you seen immunological deficiencies in correlation to where the body wants it?
So that's,
Higher or lower? Is there
yeah, so we would like to say that the big deletions are the ones that have the severe immune deficiencies, but I don't think it's panning out. And, you know, we've been wrong, well, so the ones that I think definitely that person's going to have an immune problem, we've done some of the testing and it's all been normal. So it's been difficult to make that correlation, which is why Virgil and I talked about this yesterday. We think it's going to be difficult to figure out the real cause for the immune deficiency in patients with 11q deletions, whether it's ETS1, whether it's FLY1, whether it's maybe modifying genes. So maybe there's other genes involved that are sort of impacting the immune system development, and when ETS1 is knocked out in some way and then something else is also, for whatever reason, not working well, that's when you see it. If it's a developmental thing in utero, we don't really know what's triggering it. I know that the one patient I know of with really severe T-cell lymphopenia, it was a combination of both 11q deletion as well as a translocation. So there was multiple genetic abnormalities that probably impacted the severity of the immune deficiency. But there are other patients being identified by newborn screening with very low T cells at birth who don't seem to have any other genetic cause. So it may be limited to just that gene deletion, but we really don't know. And Paul has a comment. Yeah. So everyone has it.
So it applies to those two genes perhaps, something else and other.
There is a comment from Marie on the stream. She just wanted to say thanks again. Dylan's quality of life has improved so much since he started on immunoglobulin therapy, and he would not have known about it except for the 11q conference a few years ago.
Great. See, success story. Okay. And Jessica had a question. Yeah, you're scared of that microphone now.
Just a little. So after the talk a few years ago, I had PD tested, and I believe he was completely deficient in IgM. Okay.
Yep.
I'm able to say that in words, but I can't elaborate on what that really means. He's been relatively healthy, not hospitalized. He's an anomaly in many ways, and this is just one of them.
Yeah.
But I'm wondering, could he potentially gain that as he gets older? I haven't had him tested again. should I have him tested again to see if he has any? If he's developed any?
So selective IgM deficiency, which is how I would describe that, where a patient does not make IgM, is exceedingly rare. And it's the immune finding that we don't really know how to explain.
Right.
Because it really doesn't make any sense.
Right.
It's essentially like saying, I have a car and I've never put gas in it, but I've been driving it for 5 years. Because in order to make IgG and IgA, which are the other antibody types, you have to make IgM first. It's just part of the way our immune system functions is you start to make IgM and then IgG and IgA. And there are almost no patients that I know of that really have this thing that we call selective IgM. So it's something that I would test maybe again, but and if it's low again, it's something that I would think maybe is the marker for and I hate to say this, but maybe something that would progress later on where we might see low IgG and low IgA, as opposed to something that would get better. And I don't know if I'm saying that, if I'm correct in that, but that's how I look at it, is maybe when one of those antibody levels is low, either IgA or IgM, even though IgG is normal, that may be something that would sort of trigger a more, vigilant sort of watch to make sure that we're not missing an immune problem that's developing.
I don't remember understanding before that they could have normal levels but not function properly. Is that new or did I miss that last time?
It's not new, but oftentimes we don't like to say it because it just complicates the matter. But maybe we've gotten cavalier because we've come here so many times and we want to tell you more stuff. So, yeah. It's totally it, yeah. So we actually talked about that last night. We figured it was okay to say that because people with 11q disorders understand now that the platelets may be there or maybe just a little bit low, but they don't function normally, right? So the same thing can happen, we think, and it's hard to prove this, with antibody formation. You may make the antibodies, but for whatever reason, the Y part at the top or the stalk at the bottom, just has it's made wrong. It doesn't work well. Or the T cells are there in normal numbers, but the signaling within the cell, the way it talks to the B cell, they speak different languages for whatever reason, right? They just don't have the ability to talk. And it's difficult to test for that. There are some tests that we can do, but even then, we miss it sometimes. The testing is not perfect. Because you got to imagine, these cells are so tiny, and these functional tests that we do are so complicated that errors within the lab are, sometimes the reason why it just doesn't work. These functional assays are really, really difficult to do. Sure? Oh, we have a question way over on the left. See, this happens every year, right, Lindsay? Once we get started, then the questions. I know, but we'll save questions for later, because this will prompt more questions.
Do you want me to save them, or want me to save it for later?
No. Well, I said this will be the last one. And
All
then
right.
Just shout. It's fine.
Are low, but they're not functioning properly. Does it help to have extra blood on standby if a child is having a surgery or something?
Yeah.
I mean,
Yeah.
if you're going to give them more blood and it's still not going to function properly, does it help?
Yeah, but there's a temporary benefit from getting platelets or blood, right? So you would do that, yeah. So the answer is yes. Yes. Sure. Mhm. Yeah. 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 So, not a hematologist, I'm not that well-versed with the Paris Trousseau and the bleeding protocol, but I agree that for those platelet dysfunction disorders, for surgical interventions, prophylactic platelet transfusion or other interventions make sense because you can't predict, right? And it's a temporary fix of the problem so that you don't get those types of complications.
Yeah, I think one of the problems that you describe is that, I mean, people do not know the risk. They are not aware of, so let's say a surgeon sees the results, thrombocytes are normal, hemoglobin levels are normal, so we do not need extra procedures. So in general, what we try to do in our hospital, that when a patient with Paris Trousseau needs operation, calls me and says, well, can you contact that surgeon? So I will get in touch with the surgeon, explain the situation, why it is necessary to do all this prophylactic.
This is a story that, you know, we hear over and over again for rare diseases is when they're not well versed in a particular rare disease, specialists just don't get it. And it happens in another disease that Virgil and I take care of called ataxia telangiectasia. These patients, they're not supposed to get radiation, so they're not supposed to have x-rays unless it's absolutely like life-threatening necessary to get x-rays or CT scans. Every week we get a phone call in my office about somebody, a parent who's saying, I'm in the ER and they think, you know, he needs a CT scan because he's got a stomach ache and, you know, and it makes us cringe. We have to constantly tell people, you know, that type of thing. So it's the same with bleeding disorders in JS.
There's another comment on the stream from Sherry Dimmick. She wants to say, thank you, this was very informative. We are waiting for Pneumovax 23 results for a 31-year-old son, and the information presented will hopefully help me process the results.
Great.
T-shirts for each of you.
Thank you. And
Yes,
the wine.
and the wine.
Thank
Oh,
you.
that's Virgil. This is yours.
Thank you, Lindsay.
Thank you.